Thank you for the opportunity to speak. These are my financial disclosures. So this is the story of a 63-year-old woman. She presents with bilateral painless vision loss for 1 week in the right eye and 3 months in the left eye. Her past medical and surgical history are unrevealing. Past ocular history, she had cataract extraction about 2 months prior to presentation, so about a month after the vision loss in the first eye, and she had a multifocal intraocular lens. Her family history is significant for age-related macular degeneration. She's a 10-pack-year smoker of cigarettes. Her husband passed away about a year ago, and she started drinking more after he passed away. This is her exam. So she had bilateral vision of 2400 with a paracentral fixation. She could only see the control on the color plates, and the rest of her exam is normal on the anterior segment. Her pupils were actually brisk. Her anterior segment exam shows the intraocular lens in place, and her optic nerve on the right was full hyperemic with no hemorrhages, and on the left it was pale with a normal cup. So are there any questions you would like to ask the patient?
Anyone else in your family have this? They're going to say no.
No.
How much are you drinking? How much are you smoking?
So she...
How much are you eating?
What are you eating? When are you eating?
Bariatric surgery.
And what are you getting at with these questions?
Toxic. Nutritional, genetic.
Nutritional amblyopia.
Labor, hereditary optic neuropathy.
Yeah, the hyperemia is a little worrisome with a pale nerve on the other side. But I think this also points out another issue, is that she lost her vision and then she had cataract surgery.
That seems to be common nowadays.
Yeah, so this is a common referral that we get, right?
Right, they didn't get better after cataract surgery.
And I think Andy made the point before that with glaucoma, the cupping has to fit the field. Everyone this age has cataracts, but the cataract has to fit the visual loss. And if you see 1 or 2 plus NS with a relatively acute change of vision a month before, it's not the cataract.
Yeah, I think that's a really important point. And unfortunately, some of the patients then come to us and say, well, at least the cataract surgeon tried to improve my vision. The important thing is to understand what the etiology is of the vision loss before you do cataract surgery, because you don't want that unhappy patient after cataract surgery because you missed a diagnosis that perhaps you should have considered.
Well, I don't want to get too much on the cataract surgeon. You got bilateral disease that's going to take away the RAPD. Their vision is terrible, so they probably did a confrontation field. It was full. They said, well, doing a real field is worthless. And they saw the cataract and they took it out. When they took out the cataract, the nerve is pale. But that no RAPD might be the sign that this is actually labor hereditary optic neuropathy, because that's one of the weirdest things about labor is no RAPD and brisk pupils. So you might be thinking, oh, this person's faking. But you cannot use that RAPD absence, unlike the other cases where we used it, right? We said no RAPD, probably retina. Now you got no RAPD, could still be neuroop.
A question from the audience is, could this be a tumor?
Sure.
And where?
Anterior junction, because one nerve is swollen and the other is pale. It's like Foster Kennedy or pseudo Foster Kennedy, one of those kind of things, but it's kind of fast.
How long does nutritional amblyopia occur?
Depends on which vitamin it is. So the ones that have long-term stores, B12, folate, takes months. But there's some like Wernicke, you can get that pretty fast.
Again, it really depends on how long she really was drinking. If she increased her intake after her husband passed versus what was before. You really have to ask again and again if you suspect that.
Yeah, and the other thing is patients always dismiss how much or do not exactly tell you how much they're actually drinking. You ask them how much, oh, a glass. Well, how big is that glass, right? Because that glass could be one of those super sipper cups.
Right.
And it's, 24 ounces. That's a lot different than a 4-ounce glass of wine. And I wasn't trying to be negative about the cataract surgeons. I just want to make sure that everybody realizes the point that Dr. Moster was making, and that is that cataract has to fit the complaint of decreased vision. And we want them to be, we want everybody to treat the patients appropriately and in the best way, patient-centered care.
I agree. The timing is what we're objecting to. 1
Right.
week, 3 months, too fast for cataract, not the 2,400. and the
Exactly.
No RAPD. That's all like cataract.
The hardest part about this case is the fact that it's a female and that she's 63. It really makes us start to think, what do people of that age, what do women of that age get? So we start to think meningiomas, like we're not thinking always the obvious.
That's right. If you change this stem to a 27-year-old male
We
with
slam dunk.
bilateral sequential optic neuropathy, hyperemic on one side, pale on the other, with a
Slam
central
dunk.
scotoma, no one in this room would say it's not labor.
Right.
But it's a 63-year-old woman, so now you're like, labor.
But they can get it. And so I think that's the important thing. We always talk about, well, what's the most common disease that somebody has? But patients don't read the textbooks. They're one patient coming into us with a problem. We have to really consider what are the different possibilities that can cause this presentation.
And I would just add, they're not mutually exclusive. I test the patients who don't recover, who have clear B12 or folate deficiency, or the thiambutal, they're not getting better. Test the labor, and sometimes they're the labor, so you can have ticks and fleas, okay? So if this person, even if they have B12, folate, if they're not getting better, labor.
Can you comment on these visual fields?
Central, secocentral breakout to the periphery corresponding with papillomacular bundle.
Okay, so we would want fields in this case.
Yeah, but the left eye's not as classic, right? It
Correct.
almost looks like it could be an altitudinal as well.
I would image this.
Yeah.
Okay. So this is the fundus photos. I'm going to go through them quickly because of time. And this is the OCT. It shows bilateral,
Papillomacular bundle.
papillomacular left more than right.
See, the
and-
machine just sees way better than us.
Yeah, so if you go back to that last OCT, that's actually more classic than the visual field was for that bilateral central ceco sort of defect, which really goes into the Leber's or toxic nutritional type of defects.
But even this OCT is showing the inferior nerve fiber layer sector loss corresponding with the denser superior loss that was seen on the field.
Yeah,
So it's not just papillom. The patient didn't read the book. Read the book. What's
The
wrong?
question from the audience is, if you do suspect toxic optic neuropathy, shouldn't they have more symmetry?
No.
This is this is bilateral and it's asymmetric, but it's still okay.
Again, with her age group, I would still wonder, smoking history, could this be paraneoplastic? Are we now going down the wrong direction?
Okay.
So you're thinking paraneoplastic, like
Well, I'm not ruling it
CRMP?
out with
Yeah,
that age
okay,
group
sure.
and a female.
So what would be the basic workup you'd start with?
This one, I think extensive testing is not necessary on, yes?
What are you calling extensive?
I don't know. You
A
had all
$100
those
million
things on-
MRI or?
You ordered a Lyme titer on typical optic neuritis. A Lyme titer, really, in Houston, Texas. The guy's lived there his whole life.
Would
He
you-
never went anywhere. No way I'm doing a Lyme titer.
Did you hear he never went anywhere?
Would you check for giant cell in this patient?
Yes.
You did the labs.
Yeah.
Yeah.
I'm happy with it.
Okay, would you check for syphilis?
Yes.
Yeah.
Okay. Would you do an MRI?
Yes.
Yeah.
Okay, so,
Today I'm Dr. Yes.
He's not doing anything extensive. He's
Is
just
there-
getting everything. One day at a time, one test at a time.
so the question is, would you start with the genetic testing on day one, or would you
No.
get this testing first?
All
Okay,
this first.
okay. Glad we agree.
I'm not sure that I would start with an MRI.
What?
She's got bilateral disease. What are we looking for here? Maybe you're looking for bilateral enhancement of the optic nerves. I mean, maybe.
NMO, MOG, the thing you said you were scared of. You should be scared of it right now.
Yes, but
Bilateral.
she's got 3 months history. I would really think about doing those labs. I mean, I'm okay with getting the MRI. I'm okay. We always get an MRI. We always get a visual field in an MRI. But I would actually also get labs for Leber's and labs for nutritional off the bat.
How long does a
because
Leber's lab take to come back for you?
Weeks.
4 weeks, 6 weeks.
2 weeks.
that's one of the reasons you're doing these other tests first, because you can't just assume it's Leber's and then 6 weeks later find out it's not, and then go back and say, well, I shoulda, coulda, woulda, looked for these other things.
I would just add, there are some cases of Leber's that have a little bit of enhancement or chiasmal enhancement, so that could really make this case go off the rails.
Okay, so we agree there's no enhancement on this MRI.
Agree.
Looks good.
All right, so other workup, we also got B12, folate, heavy metals. We got the MRI.
What heavy metals do you get?
There's a panel.
I know there is. But which ones affect the optic nerve?
So there's
Lead,
arsenic, copper, lead.
Have you seen an arsenic optic neuropathy?
Oh, yeah. In my arsenic optic neuropathy clinic just last week, I had 10 of them.
I mean, you've got hearing loss from listening to heavy metal.
I tested on people. I have never found a case, never, ever.
Me neither.
We've had a case of a family drinking well water, and the little boy had it.
So you want to ask about hip replacements and multiple hip replacements for chromium and cobalt, right?
Yes.
Because that's toxic to the optic nerve, right?
So the audience really wants to know why the panel is wanting a Leber's hereditary optic neuropathy workup in a woman of this age.
Because it happens. And women get Leber's hereditary optic neuropathy. It's less frequent than men, but there's some recent suggestion by the Leber's lay groups that it's not as rare in women as we think. And when it occurs in women, it occurs later in life. And there may be a protective effect of estrogen, which is why that might occur later in life. And so we have to think about Leber's in older women. My oldest Leber's patient is a woman at age 78.
Yeah, I would agree, but I would also get some of the other Bs as well, B1, B2, because that can also cause this. And I had a case just this year, which was a pretty surprising one. So we think about B12 and folate, but you can't forget B1, B2.
Right.
Does B2 show on the blood test? Because my understanding is the deficiency is very hard to pick up on a blood test.
2, did you say?
Yeah.
Riboflavin?
Get B1.
Wait, you could measure.
Wow,
Yeah.
you're questioning doing a Leber test, and you're doing a B2.
I'm not doing a B2.
Asking you.
I'm
No, to
asking,
me,
like,
the
would you do a
differentiating
B2?
feature here is the pupil was brisk, and there was no RAPD. That's why I'm thinking about Leber, okay?
I agree.
Good.
But the workup for a nutritional or toxic optic neuropathy, and sometimes the other Bs are associated with changes in homocysteine, so you might get that as well.
Can the,
Totally on board with that.
can the nutritional and the toxic precipitate the manifestation of LHON?
Yes, you have a
Think so,
predisposing genetic thing, and then you have a precipitating factor, like your husband dies and you start drinking and smoking like crazy.
Were there telangiectatic vessels off the disc? It wasn't magnified enough.
It was, we didn't think they were.
You didn't. That's sometimes seen in Leber's.
The reason to do the test is to end the cycle of testing, so that you can stop thinking about B2 and paraneoplastic and things. Just end the cycle of pain.
Okay, we're ending the cycle for you. So she tested positive for the 11778 ND4 mutation. Okay, so we gave her idebenone.
Where'd you get it?
Off the internet.
You can go in the dark web.
It exists.
There's a website, actually, and you can chat with the person. They're actually nice.
Chat with a person?
Yeah. They
Are you sure you're looking for edibenone? Your web chat?
Well, clearly it's available for people to get. I mean, we can't prescribe it. It's not approved here in the U.S., but patients can access it.
Wow.
Okay.
And most do access it.
All right, so I'm going to go quickly through this. So idebenone is an analog of coenzyme Q10 and acts as a transporter in the electron transport chain of the mitochondria, and it increases the production of ATP. So studies have suggested a trend towards visual improvement, and early treatments appears to provide the greatest benefit. So LHON is a mitochondrial disorder. There are 3 most common mutations. Usually presents bilateral acute or subacute central vision loss. Carriers of the gene may be normal until a stressor causes the manifestation, and the typical age for presentation is 15 to 30, years of age. However, it can present at any age. Usually the nerves are pseudo-edematous in 40% with some telangiectatic vessel. The prognosis is poor. EKG is warranted because of high rate of cardiac conduction abnormalities, and the treatments available are idebenone and a gene therapy vector that is currently being investigated and has some promising outcomes. So this is her fields after idebenone, and I will thank you with this.
Wow.
Thanks, Dr. Mays. And just a last thought on that, clinical trials, think of clinical trials for Leber's. Would that be something that you would want to make sure you look into? Clinical trials for patients with Leber's?
Well, there have been a few clinical trials that have completed recruitment for the wild-type gene for the 11778 mutation that have shown some promise. It's not yet published, but released in other ways of improvement. And the question on these studies that's surprising is that there's improvement in contralateral eye to the injection as well, which is being sorted out. And there's some reasonable explanations for that will be forthcoming, actually.
Thank you.
All right, thank you. And so I'm going to give a quick wrap-up of this session, and then we will ask you again the point-counterpoint question and see if your views changed from one to the next. So again, my financial disclosure is not relevant. We had a first case of transient visual loss that was due to retinal ischemia from carotid occlusion. And you should consider retinal ischemia when patients tell you that light is killing their vision. An MRI for transient vision loss is not enough in a situation like this. The carotid ultrasound was the key to making sure that patient's problem was diagnosed and then treated. And rapid intervention can save neurological function. In the second case, we saw a patient diagnosed with glaucoma, and a color vision deficit and pallor were not consistent with that diagnosis. And RAPD, as we just heard in the last case as well, may not occur in the setting of bilateral disease, so don't be fooled. And when you see a patient who has a compressive optic neuropathy, a short duration of symptoms, a green zone OCT, or lack of pallor are good signs, but never give up on them. They could still get better. We then saw a patient with atypical optic neuritis. The rapid response to steroid and normal brain MRI, we think they're good. No, they are not always good. They may herald something else. Enlargement of the optic nerve on that MRI scan and enlargement of the sheath, involvement of it, were characteristic of that myelin oligodendrocyte glycoprotein, MOG-related optic neuritis. And trauma doesn't cause subacute vision loss with steroid responsiveness. The case after that showed us that visual field defects are not always optic nerve. Retinal things can cause visual field loss as the patient's complaint. Take a careful look with the slit lamp if you're Dr. Linkoff, but then don't hesitate to get an OCT as well. And ask about caffeine use. Ask your patients these questions. They won't volunteer them to you because you're just the eye doctor. And then we saw the patient with functional vision loss. A significant field loss like she had from an optic nerve problem should give you an RAPD when it's unilateral. Be sure an abnormality on an MRI actually could cause the problem. She had an abnormality, but it just wasn't plausible that that was the cause. And you don't need a Goldman field to figure it out. There are other tricks in your bag that you can use, and even the Humphrey perimeter will work. And then finally, in this last case, if the time course for vision loss doesn't fit the cataract, be skeptical. Take another look. The optic nerve can look normal in early LHON and in some of the other diseases like nutritional optic neuropathy as well. And broad testing may still be appropriate in those cases because patients can have more than one problem. So now let's bring up that point-counterpoint question about extensive lab testing in all cases of optic neuritis. So we're going to ask you again to vote yes or no. Extensive lab workup is needed for all new cases of optic neuritis. Let's see how Dr. No did. All right.
Numbers.
So we actually are,
80-20, 86-50.
That means this class does not graduate and has to stay tomorrow.
So the no's had their influence, and we changed some of your minds.